You can find information about subscribing to this series at netrf.org/podcast, where you'll also find helpful charts, graphs, and videos that expand on this material. If you're new to NETWise, we strongly recommend you go back and listen to the series from the beginning, starting with episode 1. It will give you a solid grounding in the basics of neuroendocrine tumors and how they're treated. You can find the whole series at netrf.org/podcast and wherever you get your podcasts. Do you have a story to tell about your own NET journey? If you're a NET patient who would like to participate in a future episode, please email us and let us know. podcast@netrf.org. Welcome to NETWise. This is a podcast for neuroendocrine cancer patients and caregivers that presents expert information and patient perspectives. My name is Lauren Heider from the Neuroendocrine Tumor Research Foundation. For this episode, let's start with a little anatomy. When you eat something, it travels down what is essentially a long tube that goes all the way from your mouth to your rear end, called your gastrointestinal tract. Along the way, it passes through several organs that work to digest food and pull the nutrients out for your body to use. Here's Dr. Daniel Halprin of MD Anderson Cancer Center at the University of Texas.
After the esophagus, it goes into the stomach, and then after the stomach, it moves into the duodenum, the jejunum, and the ileum, and then from the ileum, it moves into the large bowel, right through the ileocecal valve, and then moves into the colon and eventually out of the body.
The longest portion of this tract is the small intestine, also known as the small bowel, which is made up of 3 sections. First, the duodenum, which attaches to the stomach, then the jejunum, then finally the ileum, which connects to the large intestine at the other end. The small intestine is called small because of its diameter, only about 1 inch around. But it's actually our longest internal organ, sometimes more than 20 feet long if it were all stretched out. This is the area where the most digestion happens, and it's the most common location for neuroendocrine cancer to originate. Here's Dr. Namrata Vijayvergiya from Fox Chase Cancer Center in Philadelphia.
Small bowel neuroendocrine tumors are actually one of the most common neuroendocrine neoplasms and actually one of the most common small bowel cancers. Even though NET never associates itself with common, the most common small bowel neoplasm is actually a small bowel neuroendocrine neoplasm.
And while a diagnosis of cancer is never good news, there's a lot of characteristics of small bowel NETs that can make them easier to manage than many other kinds of cancer. To begin, the vast majority of small bowel NETs are low grade, meaning that they are slower growing and less aggressive when compared to other cancers.
So high-grade neuroendocrine cancers are very, very rare in the small intestine. I have to say I have yet to see a patient who would have that.
This makes the prognosis for many small bowel NET patients very promising.
Very early stage neuroendocrine neoplasms of small intestine do have a good survival in the orders of about 90% or so at 5 years.
Even with metastatic small bowel NETs, the disease tends to progress slowly, and there are a lot of good treatment options.
The most recent data that we have about that were published in 2017, and at that time, which was before actually the FDA approval of several of our more effective therapies, the median survival for patients with advanced, meaning metastatic small bowel neuroendocrine tumors, was 9 or 10 years or so.
There are some particular difficulties in treating small bowel NETs, though. To start with, they can be especially tricky to correctly diagnose. One reason is the size, shape, and location of the small intestine itself. Because it's this very long, very thin tube, all twisted around on itself in the middle of your belly, it can be very hard to actually see what's going on inside. The normal tools you would use to look for tumors, things like standard endoscopes, just won't reach all the way through.
When you do an endoscopy from like an upper GI endoscopy, people can look in the stomach, you can look in the duodenum, but really doesn't go further up than that. If you do a colonoscopy, it looks at your entire colon, maybe the end of your small intestine called the terminal ileum, but not much. Small bowels are like really long, right? They're extremely long and they're difficult to maneuver, so it's not very easily evaluable.
Small bowel nets can also have what are called multifocal primaries, where several tumors develop at the same time in the same organ. And these tumors can be very, very tiny, too small to see with diagnostic imaging. They can be so small, in fact, that some of them are only discovered when a surgeon feels the entire length of the intestine with their fingers, a process called running the bowel. Because these tumors can be so good at hiding, they are very often left undiagnosed until they either metastasize to someplace like the liver, where the tumors are more likely to be spotted, or cause some kind of symptom. Some symptoms appear in the form of some kind of bowel obstruction or blockage, where cancerous growth in the intestine makes it harder for partially digested food to pass through the system the way it's supposed to. This can sometimes be caused by the primary tumor itself.
Even small tumors can cause, they can become blocked, or just like a plumbing problem because the lumen is further narrowed, or they cause something called intussusception, where basically because of that small tumor in your intestine, that part of the intestine is not moving in synchrony with the rest of your intestines. Like one part is telescoped into the other part of the intestine because there's tumor in there. And what it leads to is a blockage.
Another classic cause of bowel obstruction from nets happens when they locally metastasize out of the small bowel itself and into something called the mesentery, which is a sort of protective layer that surrounds it.
The mesentery is just the apron of fat in which the bowel is suspended, and there's all the blood vessels and lymphatics are running through there. And so it's common, right, for the neuroendocrine tumors to involve the mesenteric lymph nodes as they sort of work their way back from the bowel up towards the blood vessels, towards the liver.
This can cause something called a mesenteric mass.
It is basically that, in the center of your abdomen or somewhere in your abdomen, you have like this rounded structure, like a mass with like spokes or wheels on its sides. That's how you can imagine it to be. And it's deep in your abdomen with usually around big blood vessels and stuff too.
This kind of growth can cause digestive problems and other symptoms in a number of ways. First, by blocking the flow of material through the bowel, but also by interfering with the flow of blood to the small intestine.
So when the blood vessels are sort of narrowed, affected, it can affect the blood supply to your intestine, which can produce symptoms of bowel ischemia. That's the fancy word for just lower blood supply to the intestine, typically presenting as abdominal pain after you eat, after you have heavy meals, and then it gets better, and then you lose weight because you don't absorb nutrients as well because of the lack of blood supply, and there leads to swelling of the intestines can happen.
In a less well-understood phenomenon, it seems that symptoms can also be caused by the network of scarring that tends to surround a mesenteric mass, known as fibrosis.
And what it tends to do is these masses over time, because scar tissue likes to contract. If you have a scar anywhere, if you get a surgery, that area gets smaller and smaller with time, like scars contract over time. And as they contract, they tend to pull the small intestines towards each other while doing so. And that can lead to complications down the line.
In the worst cases, these physical blockages can be quite severe and debilitating.
The most severe presentation is a frank small bowel obstruction, which is when someone really can't tolerate anything by mouth at all, and absolutely nothing is making its way through the GI tract. And those folks will present with severe pain and nausea and vomiting. And really, they will frequently find themselves in an operating room very quickly to get the mechanical obstruction relieved. as quickly as possible. When things can't move through, your GI tract is making liters and liters of fluid a day that can't pass through. And so people will, they will start to get nauseated and start to vomit that up. And it's really unpleasant.
Often, though, small bowel nets cause only partial obstructions, which can produce symptoms that are much more subtle and easy to misinterpret, causing small bowel nets to be misdiagnosed as much more common digestive complaints.
We also tend to see folks who have issues with recurrent, intermittent bowel symptoms that may not necessarily be quite as severe as a frank obstruction. We certainly see folks who have recurrent issues with pain after they eat, where things will eventually make their way through the GI tract, but it just isn't working normally and the bowel is just not healthy.
A lot of my patients have been incorrectly diagnosed with irritable bowel syndrome for the longest time before they think of this.
Another way small bowel nets can cause symptoms is by producing an excess of a hormone, which in this case is almost always serotonin. This causes the constellation of symptoms called Carcinoid Syndrome. We've discussed Carcinoid Syndrome at length in earlier episodes of this series, but it's worth mentioning again here because it's more strongly associated with small bowel nets than any other kind of net.
The association is strong. We did an epidemiologic study with its own strengths and weaknesses several years ago, trying to understand this, and patients who have well-differentiated metastatic small bowel neuroendocrine tumors being most likely to present with carcinoid syndrome. In that particular manuscript, we estimated about 55% of patients with metastatic small bowel neuroendocrine tumors would have carcinoid syndrome at presentation based on the particular definition that we used in that particular study. I wouldn't use that number as being absolute, but just a sense that, but just to give us a sense that it's more common than other groups.
While small bowel nets of any stage can produce serotonin, the symptoms of carcinoid syndrome, things like facial flushing and diarrhea, very rarely appear until after the cancer has metastasized outside of the small bowel, particularly to the liver.
Typically, we feel that when the tumors are localized to just your intestine, if you release a hormone, it goes into your bloodstream, but as soon as it reaches the liver sort of degrades them, right? It basically metabolizes them. So you don't get carcinoid syndrome symptoms in early stage disease. Now that is there's never say never in medicine. Anybody can have any kind of symptoms, and I've seen it all. But typically we see that carcinoid syndrome is seen in patients with advanced disease. So when the cancer is not just in the intestine, once it gets to the liver or any other place where the blood is not pumped into the liver directly and is actually going into your circulation, and the hormones are released into your circulation, you get these symptoms of carcinoid syndrome.
Even though they can be small and slow-moving, small bowel nets do often metastasize.
It's a very interesting disease that, in a way that it doesn't, the size, we always worry about what was the size of the tumor that they took out, right? We always worry about that. We always think if it's a tinier tumor, it's probably not going anywhere. But there's not much correlation between that even tumors that are about 1 centimeter or smaller have about a 15% chance of the cancer spreading to other places. And if you're greater than 2 centimeters, there's a 50% chance the cancer is spreading to somewhere else. And that's why even though, it's a small tumor, if we find something in the small intestine, you tend to do a bigger surgery to take the lymph nodes out, no matter what the size of the tumor is.
Local lymph nodes in the liver are the most common areas for metastases, but other areas are possible.
Other area is your abdominal cavity in general. So, all the organs in your abdomen are covered with a lining called the peritoneum. That's just the lining of it. And tumors can just direct spread or through the bloodstream can just gain access to this lining. And I always, tell patients it's akin to how moss can grow over surfaces. So because it's a lining that covers all or most of the organs in your abdomen, the tumor cells can sort of form a film on this lining so as to cover the organs. So you may not see like big masses there, but it's like there is a lot of disease on the inside, like small specks which are spread in the abdominal cavity. That is called carcinomatosis. Rarely bone disease is seen too with this disease. I actually have more than a few patients who tend to develop bone metastases from this, from the neuroendocrine neoplasms of small intestine too. But, and then there's rare, I have a breast, I have a patient with a skin, but like there's, everything is heard of, but the most common ones are the liver, the lymph nodes, abdominal cavity, and maybe bone, less likely.
Because the primary tumors can be so small and less likely to be symptomatic, small bowel nets are often not discovered until after they metastasize. Frequently, these metastases are discovered by accident when a scan or other exam is being done for some other reason.
Well, my name is Quentin Hess. I'm calling from Portland, Oregon. I'm 71 years old. I was having some prostate issues about 6 years ago, and I went in for a CT scan, and when the urologist looked at the scan, he noticed there were some lesions on my liver, which I was totally unaware of. The prostate turned out to be fine, but he immediately referred me to an oncologist, and I was diagnosed then with neuroendocrine tumors. It was totally out of the blue. It just took myself and my family completely by surprise. We were just totally shocked. In hindsight, I had some symptoms. I had some flushing and I had some diarrhea, but I had no idea that they were symptoms of cancer. They did a colonoscopy and an endoscopy at the same time and couldn't find anything through there. He didn't have any idea really where the primary was. He just knew they could see these tumors on the liver. What happened then was, first I was told by the oncologist that my tumor was, well, I had numerous tumors, but there was one that was too big for surgery. And he went by the book and looked up, and there was these octreotide treatments, and that's what he suggested, once a month. And in my condition, I would get scanned every 6 months, and the doctor would tell me that, well, you're stable, but there was always a slight bit of growth, just a little bit of percentage growth. And we were like, well, how much is too much? When is this going to be a problem? And I couldn't get an answer, a good straight answer on that question. He says, well, the numbers are you're stable. So that went on for about a year or so. My wife and I finally decided to do some research on our own. So as we did some research, we discovered a NET specialist here in Portland at OHSU. And that's when the journey really began as far as getting things going on the right track. He said, I know right where your tumor is at. He pointed to my abdomen. He says, right there. I just know it's there. So he looked at me. I was, I guess, 66 at the time. He said, hey, you're young, you're healthy, you're a perfect candidate for surgery. And after hearing that it was far too large to operate on initially, it was like we were just shocked, dumbfounded that somebody thought they could take these tumors out. And so sure enough, when they went in there, it was all wrapped up and balled up. So they had to do a small incision to get it out. But he said, yep, that's the primary tumor, and they took it out. I had 2 surgeries. The first was in August of 2016. It was a laparoscopic procedure where the doctor explained that he had taken out about 1.5 foot of intestine, the lower and the upper, some lymph nodes. They had done a little bit of work on the liver as far as taking out some tumors on that. And then in October, same year, I had the open surgery. It took out about 2/3 of my liver. That one was the one that took out the large tumor along with a number of small tumors. So anyway, that was in October 2016. I've been having scans since then, and so far things have been stable. There's a little growth in some tumors, a little shrinkage in others. I've been getting lanreotide injections monthly since the surgeries and going about my life.
There are a lot of surgical options for small bowel NETs, both for localized and metastatic disease. And some of these can have really excellent long-term outcomes for patients. But small bowel NETs can remain well hidden from scans and exams, so doctors can be hesitant to describe surgery as curative. Even when all known tumors have been removed and there has been no visible activity for years, these tumors can reappear at any time.
In general, these have good outcomes. Having said that, they do carry a risk of coming back, and that risk of coming back never really goes down to zero. So, for example, if you have colon cancer, if you're 5 years out, your risk of getting, cancer coming back is very similar to a normal, unaffected individual. So you go back to your PCP. In this disease, it happens that, okay, if I'm 15 years out, now I'm safe. It's never going to come back. We cannot say that any time. So we typically recommend that we follow these patients for a longer period of time. Maybe don't follow them very frequently because these are slow-growing cancers. But we do like to follow them because if they return, we can bring in surgery and other things to sort of, improve the outcome sooner.
And it is important that patients keep in mind that small bowel surgery can also have side effects, especially to your digestion.
A lot of it depends on the specific anatomy. Many patients in this group will have the tumor arise somewhere close to the terminal ileum or the end of the ileum. There's a valve between the ileum and the cecum, which helps to sort of slow down the transit so you can absorb more out of the food before it moves into the large bowel and on out of the body. And so a lot of folks will lose that ileocecal valve, and it can take months or years for them to regain normal transit time through the GI tract, just because they've lost some of the control of the flow, and they just have to re-equilibrate. There's also, to a lesser extent, there can be issues with the gut being shorter and therefore having just not enough opportunity to absorb nutrients, although surgeons are very, very diligent about ensuring that they leave sufficient bowel to keep its absorptive capacity. So that's usually not much of a problem.
After surgery, or when surgery isn't an option, there are a handful of very good systemic therapies for low-grade small bowel NETs.
There's a finite number of therapies that we have available for patients with midgut neuroendocrine tumors. The good news is that they tend to be pretty effective in clinical practice. Probably the most commonly employed would be somatostatin analogs like octreotide or lanreotide. Both of those have randomized data. They look like they reduce the rate of progression or death by about 65% compared to placebo for patients specifically with small bowel and midgut neuroendocrine tumors. There's also everolimus, another systemic therapy, FDA approved. It also significantly reduces the rate of progression or death for folks in this group, at least as best we can tell from the randomized data. And then, of course, there's peptide receptor radionuclide therapy, or PRRT, which for folks who have somatostatin receptors that are visualized on the tumor using somatostatin receptor imaging, this was shown to reduce the rate of progression or death by about 80% in a randomized trial.
Luckily, a large majority of small bowel NETs do seem to have somatostatin receptors that make treatment with somatostatin analogs and PRRT possible.
Most of the small bowel neuroendocrine tumors have somatostatin receptors on them. What mainly determines sometimes is what grade it is. As you get a little more higher grade, sometimes you lose the receptors. So it's a Ki-67 score. And if it's between 3 and 20, those are intermediate grade. The more you move towards the 20, there's a higher chance of you losing the receptors. But in general, the small intestine ones tend to have somatostatin receptors on them.
Beyond that, there's a group of sort of local, regional, or anatomic therapies that can be deployed specifically in certain situations. The evidence base is not as robust, but certainly in clinical practice, using various liver-directed therapies or ablative therapies or surgical and resection type therapies to clear disease for specific reasons. These are all things that are certainly done in practice as well.
Up until now in this episode, we've been discussing low-grade neuroendocrine tumors that arise in the areas of the small intestine called the ileum, the section at the end closest to the large intestine, and the jejunum, the middle section.
We often refer offhandedly to small bowel neuroendocrine tumors, and what we really tend to mean in that situation is really midgut. We're really just thinking about ileum and jejunum.
These represent the vast majority of small bowel neuroendocrine tumors. There are rare exceptions though. For instance, they are very infrequent, but high-grade small bowel NETs do exist.
And then the entire treatment paradigm changes that because we know that they tend to spread a lot, and we found them spread, we tend to use chemotherapy more often in those diseases than anyone else. Again, because a lot of the symptoms are anatomic, like the location of it and everything, the symptoms are not very different, except the high-grade tumors tend not to produce as many hormones. So the diarrhea, the flushing, the Carcinoid Syndrome symptoms are not very common with that.
Also, NETs can develop in the duodenum, the section of the small intestine closest to the stomach. These are rare, quite different from the more common NETs of the ileum and jejunum, and much less well understood.
Duodenal NETs actually have a totally separate biology and course and natural history. They're nowhere near as common as jejunal or ileal neuroendocrine tumors for sure.
If it's there, typically the symptoms from that lead to more nausea, vomiting symptoms, not so much so abdominal pain, just because if you have a blockage there, things are not even passing through the stomach, so you tend to throw up more than it leading to pain. And the pattern of spread to the lymph nodes, the mesenteric mass is not associated with the duodenum, but jejunal and ileal primaries are associated with it.
But there's very, very little data. It's very challenging.
As promising as the current treatment strategies are for the low-grade ileal and jejunal tumors that make up the vast majority of small bowel NETs, there's a lot of interesting research currently going on to make them even better.
Yeah, I think there's a lot of interesting stuff that's being done right now. One area where there are a number of interesting compounds being studied would be the area of sort of other somatostatin receptor targeted agents, things where they're seeking to optimize something about the delivery of treatment based on the somatostatin receptors. So whether that's changing out, say, the radionuclide, we know a number of folks in the NETRF community have been interested in alpha-emitting peptide receptor radionuclide therapy, where you change the energy profile of the isotope, and one day we might know whether that offers patients any benefit. There are other studies looking at drugs that will just target the receptor with a different agent, so maybe switching out an agonist for an antagonist, maybe switching out radiation for something else entirely, like a toxin. So there's a lot of different studies going on in that space. There still is also, I think, substantial interest in whether immunotherapy could be useful. So far, the results have been fairly disappointing. There is a drug in ongoing studies right now, actually, that sort of mixes the last group with this group, and it uses a bispecific antibody to drag immune cells specifically to cells that express somatostatin receptors, which is just sort of a neat mix of the two ideas. And then there's still active investigation in the targeted therapy realm as well. So There's a number of targeted kinase inhibitors that are being studied, mostly in the VEGF pathway, and sometimes in combination with existing agents like everolimus or other things.
Neuroendocrine cancer is a complex disease that can be difficult to diagnose and treat. But as you heard and learned in this episode, there are many strategies that can offer promising outcomes for patients with small bowel NETs. And with continued research, prognoses will continue to get better and better. Thank you for listening to NETWise. My name is Laren Heider. I'm the Director of Education and Outreach for the Neuroendocrine Tumor Research Foundation and the executive producer of this series. It was produced by David Hoffman of Citizen Racecar. This episode was made possible by the generous support of IPSN, the Vincent E. Taylor Patient Education Fund, Advanced Accelerator Applications, a Novartis company, and Lexicon Pharmaceuticals. Special thanks to everyone we interviewed for this episode. We are grateful for your expertise. This is a production of the Neuroendocrine Tumor Research Foundation, where we're committed to improving the lives of patients, families, and caregivers affected by neuroendocrine cancer by funding research to discover cures and more effective treatments and providing information and educational resources. Please visit us at netrf.org.
This podcast is not intended as and shall not be relied upon as medical advice. The Neuroendocrine Tumor Research Foundation encourages all listeners to discuss any scientific information found here with their personal oncologist, physician, and/or appropriate qualified health professional. Listening to this podcast does not constitute a patient-physician relationship. The Neuroendocrine Tumor Research Foundation does not represent that any information provided here should supplant the reasoned, informed advice of a patient's personal oncologist, physician, or appropriate qualified health professional.